Now, do you actually need a radiologist to look at a CT scan image and diagnose the various bleed patterns that could occur in a case of head injury or trauma? Well, the answer is no. I am a radiologist and I am here to enable you all so that you will be in a position to look at a CT scan brain in a case of head injury and to say whether there is a bleed within the brain, and if there is whether it is an extradural type or a subdural type or a subarachnoid bleed, right, if it is an intracranial bleed. That is what I am here to enable you to achieve. We did this in the last video where I told you that you actually don't need a radiologist to look at a CT and say whether there is an infarct and a hemorrhage. And we are going to repeat this and apply this to trauma where you will be able to diagnose various bleeds. Look at this history now. Young male was found unconscious on the roadside after a bike accident. Right, so he started with a history of unconscious. Then he became conscious, was sent for a CT scan. During the CT scan, he again deteriorated and showed altered sensorium. So he was unconscious. In between, he has become conscious. Again, he has become unconscious. So this period of consciousness is called lucid interval, and this is associated with a very specific type of bleed, right? CT image is shown here. What is this bleed here? Lucid interval is associated with extradural bleed, right? We are going to discuss this as we go ahead. See here, a young male presents with road traffic accident was brought to the emergency room, right? His GCS is E2, M2, V3, so altered GCS, low GCS score, right? Altered sensorium, but he had no fractures and no hydrocephalus or raised intracranial tension. Non-contrast CT was performed and was found to have been normal except few tiny petechial hemorrhages and effacement of basal cisterns, which shows that there could be mild cerebral edema. Now, there is a mismatch here between the clinical findings, which are severe, that is the patient is having altered sensorium, but the imaging findings are very minimal. This mismatch is very classical of a condition seen in head trauma, which is called as diffuse axonal injury. We'll discuss this as we go ahead. Now look at this application-based question. A non-contrast CT is usually the investigation of choice for head trauma imaging. That is correct. For which of the following, however, is MRI the investigation of choice, thus making it an exception to this rule? This is again diffuse axonal injury in which MRI becomes the investigation of choice. Why? How? What is this diffuse axonal injury? Right, this is something we'll study as we go ahead. Now, I intend to make you an expert in the diagnosis of head trauma imaging from an expertise level of amateur, that you are right now here. We are going to achieve it by following certain steps. So we'll first look at some basic concepts of head trauma imaging. We'll learn identifying acute bleed on CT. We'll just have a look as to how acute bleed looks like on a CT. I'll then give you a very simple diagnostic algorithm or a flow chart. And by using this flow chart, we will really have fun in this particular video. You'll realize after the next 10 to 12 minutes of our discussion how easy it is actually to interpret all these head trauma related scans. Let us start on this particular transformation. So for head trauma imaging, let us look at certain insights. Tell me, what will you do? Whether you will do a CT or an MRI? I said whenever you are confused what to achieve, you must first think about the concept of time. Is time crucial in this particular diagnosis? The answer is yes, absolutely yes. In head trauma, the patient is unconscious, right? There could be a large EDH or an SDH which could be compressing on the brain, and therefore time is crucial. And therefore remember, the investigation of choice for head trauma imaging is CT scan, right? And here contrast is not required, so it is always a non-contrast CT, which is the investigation of choice for head trauma. But there is one exception in which MRI is preferred, and that exception is called as diffuse axonal injury, and this is something that we'll discuss in detail when we go to the discussion of diffuse axonal injury. Yes. Now, when is CT scan done? Is CT scan done in each and every case of head trauma? The answer is no. So American College of Radiology suggested an appropriateness criteria. This is the most recent update, remember, which gives us very clear-cut guidelines as to when a CT scan is to be done in a head trauma patient. So you could be asked a question, all of the following are indications for doing a CT in head trauma except. So that type of question could be asked. So let us have a look. The judgment basically is based upon the Glasgow Coma Scale assessment. So if the GCS score of a patient is 13 to 15, it is classified as mild traumatic traumatic brain injury. If the score is between 9 to 12, it is classified as moderate traumatic brain injury. If the GCS score is between 3 to 8, very low score, so this is a severe traumatic brain injury. Or if there is a penetrating cranial injury, that is the cranium has been breached. Now, when you look at this severity classification, remember, moderate or severe traumatic brain injury and penetrating cranial injury, you can do a CT scan right away. Right? So nothing else is required. If you find that the severity is moderate or severe based on these Glasgow Coma Scale score values, or if there is penetrating injury, you can do a CT right away. Now, if the brain injury is mild, then can you do a CT? You can do a CT only if additional findings are present. What are those additional findings? Let us have a look. Right? So what additional findings are required? So if you see that the GCS score is 13 to 15, so it is mild injury. And if you find any of the following features, that is if the patient has headache, if the patient has vomiting, which is a sign of intracranial injury, if the age of the patient is more than 60 years, because these are then prone, to having specific types of bleeds within the brain. We'll discuss that as we go ahead. If there is history of drug or alcoholic intoxication, because then the neurological status assessment might not be very accurate. If there are deficits in short-term memory, this is also an indicator of intracranial injury. There is physical evidence of trauma above the clavicle. There is post-traumatic seizure or a focal neurological deficit or a coagulopathy, because that is again a predisposition to intracranial bleeds. So in mild traumatic brain injury, if any of these findings is present, then it is definitely an indication to do a CT. Now, how do we identify bleed on CT? Look at all these images here. All I want you to look for is to try and identify a bright area or a hyperdense area within the cranium. Can you see a hyperdense appearing area in the cranium, inside the cranium here? Yes. See here. Can you see a hyperdense appearing area here? Yes. See here. Can you see a hyperdense appearing area here? Yes. Can you see a hyperdense appearing area here? I'm not saying that these are all cases of head injury or trauma. There are different causes for bleeds in these patients. Right? Therefore, the diagnosis in each one of these images is different. But what I want you to achieve here is to form a visual impression, because this visual impression is very, very critical. Just try and identify bright area. Can you see the bright area here? See, can you see the bright area here? In this particular image also, in this particular image also. This is how acute hemorrhage appears on CT scan. Right? I want you to be able to detect acute hemorrhage or bleed, and it's relatively easy to do that because it appears bright or hyper dense. Now we come to the point where I am going to give you a very, very, very simple CT interpretation protocol for head trauma. If you follow this protocol well, believe me, you'll be able to make a diagnosis in almost all the cases of head trauma imaging. Let us start. Once you're looking at a CT scan in a head injury patient, you ask yourself, is there a bleed? We have seen recently in the previous slide, we have seen how acute bleed looks like. How does it look like? It appears hyperdense or bright. So look for such hyperdense area. If your answer is yes, then you try to classify where that bleed is located. You say whether it is intraaxial, means whether it is inside the brain, or it is extraaxial, meaning it is outside the brain parenchyma. If it is intraaxial or it is extraaxial. How do you define that? Remember, never go by the appearance, because the appearance can be misleading, right? It is subjective, and therefore we have to follow objective signs. What is the objective sign of an intraaxial bleed? Bleed within the brain parenchyma. If there is bleed in the brain parenchyma, remember that the brain will always react to it in the form of a rim of edema around that bleed. So if you see a hypodense rim around it, that hypodense rim is because there is a rim of edema around that bleed. If you see that rim of edema, it means that the bleed is intraaxial or inside the brain. But if the bleed is outside the brain, there will be no edema, but there could be cortical shifts. If this is the cranial vault and this is the brain parenchyma, if you see a large bleed here outside the brain, if the bleed enlarges in size, what will happen? It will push this cortex inside like this, and this is what is called as cortical shift. If you see that there is history of, trauma, there is bleed, and there is bleed inside the brain, right? Because there is rim of edema, you say that it is hemorrhagic contusion. Another possibility here is that it could be diffuse axonal injury also, but it presents in a little bit different manner because there's no edema. These are petechial hemorrhages, and therefore if you see a large bleed and edema, it is always hemorrhagic contusion. That's it, diagnosis is done. But if you see a bleed and you don't see edema, you see some cortical shift, which means that the bleed is outside, then you must look at the shape of that bleed. If you see that the bleed is biconvex like this, see, this is biconvex, right? Convex on both sides, right? Or the shape could be crescentic like this, so concavo-convex. So what are these shapes? This is biconvex, or it could be crescentic or concavo-convex like this, or the bleed could be linear. When it is linear, it will be linear when it is in the sulcal space, because sulcal space is linear. So if there is blood in the sulcal space, it will be linear. Or if there is blood within the basal cisterns, right? Basal cisterns are CSF spaces at the base of the brain. If there is blood in the basal cistern, so remember, the shape will give you the diagnosis. If it is biconvex, it is extradural bleed. If it is concavo-convex or crescentic, it is subdural bleed. And if it is linear in the sulcal space or in the basal cistern, blood within the sulcal space or the basal cistern is called as what? It is called subarachnoid hemorrhage, right? A protocol as simple as this, if you follow it meticulously, you'll get the diagnosis in each and every case. So before I give you a test, now every image that I show you in this particular video is actually going to be a test for you. So along with me, you have to follow this protocol, and I'm sure we'll be able to come to a diagnosis. Let us repeat this once, just quickly. So just look at a CT and you ask yourself, is there a bleed? If there is a bleed, you say whether it is intraaxial or extraaxial. How do you determine that? You look for, yes, you look for edema. If there is edema around it, the brain has reacted to it, which means that the bleed is inside the brain, intraaxial, right? If there is no edema and the cortex is pushed inside, which means that the bleed is outside the brain or extraaxial. If you see history of trauma, bleed inside the brain, your diagnosis has to be hemorrhagic contusion. But if you see there is, trauma, there is a bleed outside the brain, then you look for what? Then you look for shape of the bleed. If the bleed is biconvex, it could be crescentic or concavo-convex, or it could be linear in the basal cisterns. If it is biconvex, it is what? It is EDH. If it is crescentic, it is what? It is SDH. And if it is linear in the sulcal space, it is what? It is subarachnoid hemorrhage. Blood within the basal cisterns is also called subarachnoid hemorrhage. Now gear up, get ready. Every slide here, we are going to have fun, right? You will be able to make a correct diagnosis. Let us try out on the first image. Say, is there a bleed? Yes, there is bleed. There are multiple areas of bleeds. Where are these bleeds? See here. Can you see all these hyperdense areas in the brain parenchyma? So all these are bleeds. Are they inside or outside? Watch carefully. Look, just adjacent to this bleed. Can you see this hypodense rim around it? See? Can you see the hypodense rim around it? Around each and every bleed that I've put out here, can you see that there is actually a hypodense rim of edema around it? If you see a hypodense rim of edema around it, it means that the bleed is where? It is inside the brain. So inside the brain means, what is your diagnosis? Your diagnosis is hemorrhagic contusion. So what is this? This is a bilateral frontotemporal hemorrhagic contusions within the brain parenchyma. Remember that hemorrhagic contusions are most commonly seen in the frontal lobes and the temporal lobes. Why? Because the brain is sitting on that floor of the cranial fossa there, anterior and middle cranial fossa. When there is a jerk of trauma, right, at the time of trauma, the brain actually hits the adjacent bone, and that is the reason why in the basifrontal and basitemporal regions, hemorrhagic contusions are most commonly seen. So this is classically a hemorrhagic contusion. Now look at this particular image here. See, this is right, this is left. So tell me, look at this particular image. Is there a bleed? Yes, definitely. There is a hyperdense appearing area which is seen here. Is it inside or outside? How to determine that? Look for edema. Do you see any edema here? There is no edema, but the gray matter has in fact been pushed inside, isn't it? So this is cortical shift. So there is no edema and there is cortical shift. So what is this? This looks like an extraaxial bleed. Now, when there is an extraaxial bleed, what you should do, you look at the shape. What is the shape of this bleed? See, the outer margin is convex. The inner margin is also convex. So what is this shape? This is your typical biconvex shape, isn't it? So biconvex shape means what? It is EDH. So what is this? This is right-sided acute extradural bleed, isn't it? See how easy this is? Let us move on to the next image here. See, this is right, this is left. Is there a bleed? Yes. Where is the bleed? Inside or outside? Look for edema. There is no edema and the cortex is being pushed inside. So there is cortical shift, no edema. So which means that the bleed is extraaxial. Look at the shape of the bleed again. This is biconvex, right? So biconvex shape bleed is what? Biconvex shape bleed is extradural bleed. Now it is on the left side, isn't it? So this is acute left-sided extradural bleed, right? Or EDH. Now why is an EDH biconvex in shape? Now let us look at this quickly. See here, if this is the skull vault and this is the outer layer of the dura, this outer layer of the dura is very closely attached to the inner table of the skull vault, except at certain places where there is an arterial radical, which is what? Which is the middle meningeal artery radical. Where there is a middle meningeal artery radical, this dura just goes over this arterial radical and then again it is stuck to the dura. Whenever there is a skull fracture here, this arterial radical will be damaged. So what will happen? It will create bleeding where? It will create bleeding outside the outer layer of dura. So this is extradural. So it will accumulate here. But do you realize now one thing? The bleed is arterial in origin. So it is coming out at a very, very high pressure, isn't it? Then it is actually coming out in a very limited space because the dura is stuck to the inner table of the skull, right? So this arterial blood actually tries to spread in this direction and this direction, trying to separate the dura away from the inner table of skull. Whatever area it succeeds in separating the dura, it fills up entirely. So it takes a shape like this. If it is a large one, see what will happen? It will take a shape like this. And see here, the inner margin is convex because the blood is bulging out, right? Bulging inwards, right? In that limited space. The outer margin is convex because that is the shape of the inner table of skull. So this is how a biconvex bleed is created. So this is the reason why, an EDH appears biconvex. Few more things about EDH that I want you to know is because, it is related to this particular, very closely related to the inner table of the skull where the dura is actually fixed. Therefore, if it encounters a skull suture, it cannot pass it. So EDH cannot cross the skull sutures. EDH cannot cross the skull sutures, but EDH can very readily cross the midline. Right? So it cannot cross the skull sutures because the dura is anchored there, so it cannot cross it, cannot separate it, right? But it can cross the midline. So this is about the shape of EDH. Now there are a few clinical peculiarities which are also associated with EDH. One is called lucid interval. We saw this in that question. Patient is unconscious, right? Unconscious. Again, patient in between becomes conscious and again patient becomes unconscious. So this central time period where the patient is lucid or conscious for a short period of time, a short interval of time, is called lucid interval. Another clinical phenomenon associated with EDH is called talk and die syndrome, which is similar. There is an accident, right? Patient after the accident is walking, talking, doing everything very well, but because there is an arterial bleed which is building up in the brain, at one point, because that arterial bleed suddenly enlarges in size, it compresses the respiratory structures, the patient collapses and dies. So this is what is called as talk and die syndrome. Let us move on to the next image now. See, what is this image? This is the right side. This is the left side. Is there a bleed? Yes, there's definitely a bleed here. See, you are able to see a bleed on the right side. Now, where is this bleed? Is it inside or outside? Is there any edema that you see? No. But can you see the cortex has been pushed inside? So there is no edema. There is cortical shift. Where is this bleed? This bleed is outside. Look at the shape of this bleed. Look at the outer margin there, right? Can you see? The outer margin is convex, but the inner margin, if you see, is concave. So what is this shape? This is a typical concavo-convex or crescentic shape. Crescentic shape is what? SDH. So this is right or left? Right. So this is acute right subdural hemorrhage. as simple as it can be. Let us look at one more image here. So this was one of the questions which was recently asked. See, is there a bleed? Yes. Right side, left side. Which side is the bleed? Left side is the bleed. Look at this bleed. Yes. Is it inside or outside? See, there is no edema and the cortex has been pushed inside. So this is definitely outside. Look at the shape of that bleed. The outer margin is convex, whereas the inner margin is concave. So this is crescentic appearance. Crescentic appearance is SDH. So what is this? Acute left-sided SDH. Yes. Now, why is SDH crescentic or concave or convex? Right. Let us quickly have a look. Now, we have discussed, when we discussed EDH, the source of bleed in EDH was what? It was middle meningeal artery. What is the source of bleed in SDH? Now, if this is the skull vault, see, if this is the skull vault, this is the brain parenchyma, right? In SDH, the source of bleed is these bridging cortical veins that arise from the cortex and they reach the dural surface. So what is the source of bleed? It is these bridging cortical veins. Now when the brain atrophies, right, if the brain parenchyma undergoes atrophy, what will happen? It will shrink inwards. Because the brain parenchyma is shrinking inwards and these veins are traveling outwards, these veins are being stretched. So what happens in the elderly age group, even with trivial trauma, minor trauma, these veins can rupture or these veins can get torn. When these veins get torn, it begins to bleed in this space. What is this space? This is the subdural space. Is it a limited space? No. Is it an arterial blood coming out at a high pressure? No. It is a venous blood coming out at low pressure in a large potential space. So what does all this blood do? This entire blood simply accumulates on the surface of the brain, whatever area is available. And if you look at this shape now, this is your crescentic shape which is created. So this is your crescentic shape or concave or convex shape which is created. And this is the reason why, right, subdural bleeds are crescentic in shape. Yes. Now, few clinical phenomena associated with SDHs we have seen with EDH. There is lucid interval. Remember, SDH, because they accumulate insidiously, right, within the brain, they are often asymptomatic, right? So they don't create any specific neurodeficits. Patient may have mild headache, but nothing else. Often, we have already discussed in elderly patients, they are associated with very trivial trauma because these veins are already stretched because of brain atrophy. So even in response to trivial minor trauma like a sudden jerk to the head or mild banging of the head to the wall or just fall down resulting in a subtle jerk, right, these veins will tear off and there will be an SDH. So only with minimal trauma or trivial trauma SDH can occur, especially in the elderly age group. Yes. Now let us see what changes in that bleed when a bleed passes through acute, subacute to chronic stages. Now, an acute bleed is said to be a bleed which extends from few hours to few days. What is a subacute bleed? A subacute bleed is one which extends from few days to few weeks, whereas a chronic bleed is one which extends from few weeks to few months. Now, what happens histopathologically, right, when there is an acute bleed? When there is an acute bleed, there is a hematoma or a blood clot which is formed at the site. Now a hematoma or a blood clot has a density which is definitely higher, right, as compared to normal blood, isn't it? And therefore an acute bleed appears bright or hypertense. We have already seen acute bleed, how it appears. What happens as days passes and say a few weeks have passed? What happens? That hematoma or blood clot is actually broken down. There are macrophages who come there. They will phagocytose these broken products or these degradation products of the blood clot. Hemoglobin will be broken down. Hemoglobin degradation products will be phagocytosed and they'll be taken away. So what happens as days passes? What is happening to the density of the blood clot? Because it is being broken down, the density is going to decrease, isn't it? And because the density decreases, an acute bleed appears hyperdense, but a subacute bleed appears now isodense to the brain. It appears gray, not white, not bright white. What happens if there are few years have passed? The entire blood clot is broken down. All the broken down products are phagocytosed and taken away. There is an empty space created there, and an empty space in or around the brain is filled up with what? It is filled up with fluid or CSF. And how does fluid or CSF appear on a CT scan? It appears hypodense. Yes, So now can you make out? An acute bleed appears hyperdense, a subacute bleed appears isodense, but a chronic bleed appears hypodense. Let us look at some images. Look at this bleed. Is there a bleed? Yes, right, left side. Acute bleed appearing bright. It is outside the brain, no edema. Look at the shape. It is crescentic shape. So what is this? This is a acute left-sided STH. Look at this image. Is there a bleed? Watch carefully. It is very difficult to detect a bleed in this particular case, but if you watch carefully, there is a isodense appearing crescentic shaped bleed here along the surface of the brain, right? See, because it is isodense, you realize it is very difficult to diagnose it. If it is a small bleed, it can be missed, right? So because it is not hyperdense, it is isodense, we have discussed. It is seen in what stage? This is subacute bleed. Look at this image now. Therefore, right, seeing this image, we realize that diagnosing a subacute bleed is very difficult on CT. Small bleeds can be missed, and therefore if your examiner specifically asks you what is the investigation of choice for a subacute bleed, specifically if he is poking you and asking you a specific question like this, only then remember the answer will be MRI, because subacute bleeds are isodense on CT, they become very difficult to diagnose. Look at this now. Can you see a crescentic collection on alongside the surface of the brain? But what is its density? It is appearing darker, so it is appearing hypodense, isn't it? So what is this? This is a chronic bleed or chronic STH. So try to form a visual impression in this image. Can you see that acute bleed appears hyperdense, subacute bleed appears isodense, so difficult to diagnose. Investigation will be MRI, investigation of choice will be MRI, and chronic bleed appears hypodense. Yes, now let us come back to another image. Look at this CT. Tell me, is there a bleed? Can you see a bleed in this particular CT? Yes, there is a bleed. Where is that bleed? Is it inside or outside? It looks inside, isn't it? But the first thing I told you when we discussed this protocol is never go by the appearance. Go by objective criteria. What is the objective criteria? Edema. Is there any edema? See, no. There is no edema around it at all. Right? So if there is no edema, it is supposed to be outside. But what is its shape? Can you see it is linear? See, I'll just draw a line alongside it. Can you see it is linear? Can you see this bleed is linear? Why is it linear? It is linear because this bleed is where? This bleed is within the sulcal space. And if it is within the sulci or the sulcal spaces, it is called as what? It is called subarachnoid hemorrhage, isn't it? So what is this? This is bilateral acute subarachnoid hemorrhage. There is bleeding within the sulcal spaces. This is not a case of head trauma. We have seen this very image, right, in stroke imaging. So this is not head trauma, but still the protocol can actually help you. Is there a bleed? Yes. Where is the bleed? Inside or outside? See, there is a bleed here. It looks inside, but there is no edema around it, so it has to be outside. Where is it? This bleed is nothing but within the basal cisterns, and blood within the sulcal spaces or blood within the basal cisterns is what? It is subarachnoid hemorrhage. So this is acute SAH. We have discussed it in stroke imaging that this is very likely to be due to aneurysmal rupture. So even if there is no trauma, actually this protocol will help you just to determine whether the bleed is inside or outside it, and then based upon the location you will be able to come to a diagnosis. Now we come to another important condition which is called as diffuse axonal injury. What is diffuse axonal injury? Now your books have unnecessarily complicated it. Diffuse axonal injury is actually very easy. It is in fact a history clincher. What is the history clincher? It is a non-improving altered sensorium in a head injury patient with normal early CT brain. So there was a recently asked question on this very topic. So what happens? Patient has a history of head trauma. Patient is unconscious, brought to the hospital. There is evidence of head injury externally also. So the surgeon thinks there must be a big EDH, SDH, needs to operate this patient. So he keeps everything ready for surgery, takes the patient for CT scan. But the CT scan surprisingly comes out as completely normal. Sometimes there could just be mild cerebral edema on the CT scan. Occasionally some petechial hemorrhages may be seen. But see, CT scan is more or less normal, but the patient is having altered sensorium, and more importantly, the sensorium of the patient does not improve, right? So the patient remains to be unconscious. Say for 2 days, 3 days, 4 days, 5 days, 1 week has passed, patient is still unconscious. What is wrong with this patient? The patient is suffering from diffuse axonal injury. This is the history clincher. What happens? See, if you look at the structure of the neuron has a cell body and a neurofilament, right? Now cell body and a neurofilament. Whenever there are shearing forces or distracting forces that are exerted on the neuronal structure, the neuron gets twisted or stretched. The neuron breaks at its weakest point. That is the junction of the cell body and the neurofilament. So, do you realize therefore, because the cell has broken here, what is this injury? This is actually a axonal injury. What has happened? Axon has broken, but it is in a diffuse manner in the brain. Means what? Out of the million neurons in the brains, few thousand neurons have broken off. And because these few thousand neurons have broken off, patient is having altered sensorium. Will these neurons join up with Fevikwik and start working again? No, this is a permanent break, and so this is non-improving altered sensorium. Patient remains unconscious. But remember, this will not give rise to a hemorrhagic contusion because this is not a gross injury. This is a cellular level injury. So therefore, the early CT scan is therefore normal. But what happens as time passes by? As time passes by, at the site of this break, a tiny petechial hemorrhage develops. And the diagnosis of diffuse axonal injury is made by detection of these multiple tiny petechial hemorrhages. Because some time has now passed and this is not a critical time emergency, MRI also has certain specific sequences that helps us detect these petechial tiny hemorrhages better. And therefore, remember, MRI is the investigation of choice in case of diffuse axonal injury. Rather, there are specific types of MR sequences which are called as gradient echo, that is GRE, or susceptibility weighted imaging. So gradient echo or susceptibility weighted imaging is done. There are black spots of petechial hemorrhage. These black spots in MRI term are called as blooming. So black spots or blooming is seen on gradient echo or susceptibility weighted imaging. Where is it seen? See, most common site of blooming is where the site of break is. Where is the site of break? At the junction of cell body and neurofilament. Cell body is located in gray matter. Neurofilament is located in white matter. Where is the break? At their junction. So most common site of blooming is gray white matter junction. Second most common site of blooming is in your break petechial hemorrhages is corpus callosum, and third most common site is the dorsolateral brain stem. Now, because this indicates extensive injury, these sites are also used for grading of diffuse axonal injury. If it is only at gray white matter junction, it is called grade 1 or stage 1. It is at corpus callosum, it is called grade 2. And if it involves the brainstem, it is called grade 3. This is everything that you need to know about diffuse axonal injury. See, look at the name, it is telling you what is the injury. It is an axonal level break in a diffuse manner in the brain parenchyma. It is a history clincher, non-improving altered sensorium, head injury with normal early CT brain. Why is the early CT brain normal? Because this is a cellular level injury. With time, petechial hemorrhages develops, which is better detected on MRI. So MRI is investigation of choice. MRI sequences, gradient echo, susceptibility weighted imaging show black spots are blooming where? Most commonly at gray white matter junction or corpus callosum or dorsolateral brainstem. This is what is diffuse axonal injury. Look at this CT that was done in one of the diffuse axonal injury patients. If you look at this CT, can you see this multiple small petechial hemorrhages? Can you see that almost all of them are located at gray white matter junctions? As compared to CT, MRI I have said is investigation of choice. Why? Because two sequences are done. One is gradient echo and the other is susceptibility weighted imaging. I said black spots or blooming will be seen. Can you see black spots in these scans? See multiple black spots, mainly at gray white matter junctions. Can you see SWI is definitely better than GRE, susceptibility weighted, because it is detecting multiple more black spots which were not seen in gradient echo, right? Multiple more black spots are detected here, right? So this is what is diffuse axonal injury. Yes. Now look at this particular image. Is there a bleed? Yes, let us answer. Let us follow the flow chart here. Is there a bleed? Yes, there is a bleed here. See, is the bleed inside or outside? Look for edema. Is there edema? There is no edema. So it is outside. Look at the shape of that bleed, right? Shape is biconvex like this. See. So what is this? Biconvex shape is what? It is EDH. So this is acute left-sided EDH. But look at the black spots there. If you watch carefully in this CT image, what are these black spots? See, they are jet black Like air, they are darker than CSF also. So what is this? This is free air within the cranial cavity, intracranial air. It is given a name. It is called as what? It is called pneumocephalus. Pneumocephalus means air within the intracranial cavity. It happens because there is, along with head injury, if there is a skull base fracture, which involves the paranasal sinuses, most commonly the frontal sinus here, that is the source from where air actually enters into the cranial cavity. So this is called pneumocephalus. This is a surgical emergency, has to be operated. The fracture has to be closed so that the more and more air does not enter it. What will happen if more and more air enters into the brain? It creates a condition which is called tension pneumocephalus. What is tension pneumocephalus? When this air within the cranial cavity creates a compression, or the subdural air creates a mass effect or a compression on the brain assumes a peaked appearance like this, or a peaked or a stretched appearance like this. This is given a name. This is called your Mount Fuji sign. So this is peaked appearance because of tension pneumocephalus. This is called as the Mount Fuji sign. Right now, there could be skull fractures. Remember, see here you are able to see a depressed skull fracture. This is the only fracture which is well seen on radiographs though. So X-ray has no role now. Should you do a skull X-ray in a case of head injury? No. Books say that a skull X-ray has no role. Don't waste time, directly do a CT. Right. So what is the investigation of choice for detection of skull fractures? It is CT scan of the head. Remember, a depressed fracture or a signature fracture, as it is seen here, right, may sometimes be visible on a X-ray, though X-ray has very poor role. A specific type of skull fracture I want you to know, which is called as a growing skull fracture or a leptomeningeal cyst. What is this? This is simply, remember, a non-union of a skull vault fracture. See, this is a very interesting and very peculiar condition. See what happens. There is a skull fracture. Suppose this is the bone, right, and in between the skull vault there is a defect or a fracture which is created. Now what happens? Through this defect, the dura is going to herniate. So the meninges, they herniate within it. So when there is a fracture, right, what happens when there is a skull fracture? So let us see how this fracture actually develops. Initially, it starts with a fracture, right? As a result of this fracture, there is a dural tear which is set up. Because there is a dural tear, the leptomeninges, that is arachnoid plus pyometer, they herniate into the fracture site along with their vessels. Now these vessels are pulsating. So these pulsating vessels, they affect the bone around it. So this creates a non-union at the site of fracture. Non-union of the fracture. Rather, because of these pulsations, the bone gets resorbed or remodeled, and as a result, over time, this fracture begins to widen or grow in size. Therefore, it is called growing skull fracture. Because the leptomeninges means what? Arachnoid plus pyometer. They have herniated into it. This is also called leptomeningeal cyst. Yes. So this is what is a growing skull fracture or a leptomeningeal cyst. Now see here, look at this clinical scenario. A 52-year-old male, head trauma with skull base fracture is a predisposing condition. Presents with chemosis, right? One eye is swollen, say the left eye here in this particular patient, and there is pulsatile proptosis. This is very peculiar. A CT brain and a digital subtraction angiography is done. So what do you see on CT? Now let us look at these images. See here. This is the area of the sella turcica. On either side of the sella, on either side of the sphenoid bone, we have the cavernous sinus. Look at the cavernous sinus on the right side. It looks normal. Look at the cavernous sinus on the left side. It is enlarged. Look at this prominent vein, right? It is extremely tortuous. Here we are at a cross section to that vein, so we are able to see it. So what happens? Why is there pulsatile proptosis? Is because there were skull base fracture. Here, the internal carotid artery, which also runs in close, correlation with the sphenoid bone there along the cavernous sinus wall, gets traumatized. There is a communication that develops between the carotid artery. See here, this is the right-sided internal carotid artery dividing into middle and anterior cerebral. Look at the left internal carotid. It is opacifying the cavernous sinus as well because there is a communication that developed between them. This is what is called as the carotico-cavernous fistula. A clincher of diagnosis for theoretico-cavernous fistula is this finding of pulsatile proptosis. Why is there pulsatile proptosis? Because the superior ophthalmic vein which communicates with the cavernous sinus is now getting this arterial flow. So there is a retrograde arterial flow within the superior ophthalmic vein, and that is what is creating that pulsatile proptosis. The investigation of choice for theoretico-cavernous fistula will be either an MR angio or a CT angio. If they ask you what is the gold standard, then remember, for all vascular abnormalities, gold standard is invasive catheter angiography, or the DSA, digital subtraction angiography, as will be done here. So now with this head trauma discussion, what are the clinical insights that I want you to carry with you? Remember, head trauma is a critical emergency, so investigation of choice will always be a non-contrast CT. We are able to diagnose various injury patterns on non-contrast CT. What is the role of MRI? MRI is used only in specific situations, that is diffuse axonal injury. Yes, we have seen the diagnostic protocol. See whether there is a bleed, see whether it is inside or outside. How to look for that? Look for edema. If there is edema, it is inside. If there is no edema and cortical shift, it is outside. If it is inside, trauma, right, it is hemorrhagic contusion, that's it. But if it is outside, look at the shape. Biconvex is EDH, crescentic or concavo-convex is STH, and linear shaped, right, is SAH. Yes, so what is this bleed? See, this is classical clinical history of lucid interval. We have seen this. Patient was unconscious, then he regained consciousness, again deteriorated, and on the CT we see a extraaxial, no edema, but biconvex bleed. So what is this? This is EDH. So this is extradural hematoma. Middle meningeal artery is the source of bleed. Look at this patient, young male, poor GCS, so altered sensorium, no fractures, no hydrocephalus, no raised ICD. NCCT was found to be normal, except what? Except petechial hemorrhage and effacement of basal cisterns, means mild edema. Petechial hemorrhage is in head trauma, right, with altered sensorium, is diffuse axonal injury. So this looks like diffuse axonal injury. MRI is the investigation of choice. So non-contrast CT is investigation of choice for all head trauma, except MRI is investigation of choice for one condition. We have discussed this in detail as to why, what is the concept, what actually happens in diffuse axonal injury. So MRI is the investigation of choice for diffuse axonal injury. I hope you have loved this session. We have created a simple flowchart. Using this, you will be able to make all the diagnosis.